the voice of the patient is just so powerful. And so as I wrap up these amazing couple of days with you here, I want to go back to yesterday and just have you focus a little bit on the lessons that we learned from yesterday, beginning with the changes that we need to make at the patient level. And that is to start with shifting the conversation from what's the matter to what matters to you. And really the dramatic importance that we've heard throughout the couple of days on sitting with patients and setting goals with them, because it's so critical that we understand the patient's assets and preferences before we decide the clinical treatment plan. And I mentioned yesterday that we also have to change the way that we're working at an organizational level. So there's lots of changes at the patient level. But at the organizational level, we also have got to change the way that we're working. And as I travel the world, I'm finding lots of new ways to work, lots of ways that patient engagement can actually change the clinical outcomes that we're seeing. So let me tell you a story. Just last year in May, after I left here, May 17th, I was in an academic medical center in Jönköping in Sweden. It's an 850-bed hospital, a major hospital, and I was walking through the hospital, and I came into a unit that I didn't know what it was. It was very unfamiliar to me. So I said, "What is this place?" And they said, "Oh, this is the patient self-dialysis unit." Now, I know patients do self-dialysis, and I know they do self-peritoneal dialysis and hemodialysis, and I know some patients do it at home. But I had never seen a hospital unit where every patient did their own dialysis. And so I said, "Well, tell me about this place, and how did it come to be that you built a wing on a hospital that was for patients to take care of themselves?" That was mind-blowing to me. And they said, "Well, we're very innovative. We've been working with IHI for a long time." And I said, "No, really, tell me the real story, because I've never seen this before." And throughout the course of the day, I found the person who pioneered this, and it's this guy, Christian. Christian is a young guy. He was in his 20s, and he was an aviation mechanic at Saab when he came down with glomerulonephritis and ended up on dialysis. And he was a triathlete, and he had his whole life ahead of him. And being a mechanic, now he ends up on dialysis. After a couple of weeks, Christian said to his nurse, "Can I do that myself? I think I have been watching you, and I think I can do that myself." And so his nurse said yes. And what you see now is he started doing it. And then the lady in the next bed to him said, "What are you doing?" And he said, "I'm doing my own dialysis." So she said, "Teach me." So Christian taught the 73-year-old lady in the next bed, and pretty soon they started teaching others how to do it. They now, at this academic medical center, have a goal that 75% of the patients on dialysis should be doing it themselves, and they're already at 60%. So there are some patients who are too sick, and they clearly will need help, and they're taken care of in a different unit. But in this unit, the patients let themselves in with a card key, an electronic card key, whenever they want. They come in, they do all their own testing, they connect themselves, and they do all of their own dialysis. So I spent a whole day with Christian, and I learned so much from him. I said to him, "Christian, where did you find the courage to say to that nurse, 'I want to do my own dialysis'?" And he said, well, he had done a lot of research, and he found that dialysis survival rates in the United States are very short compared to Europe and Asia. Dialysis rates, patients' life expectancy and the quality of their life in the United States is not as good. And when he started to do some investigation, he found that we dialyze our patients in the United States shorter periods of time. We think it's for convenience and all, but we keep patients on each dialysis treatment shorter than they do in Europe and in Asia. So he started to do some experiments on himself, and he found that the longer he dialyzed himself, or the more frequently he dialyzed himself, the better he felt. He said that his life expectancy, his ability to have kids, he thought was going to be impacted by the completeness of his dialysis. And he also taught me about something that's commonly known in the renal field called post-dialysis syndrome. And he said that when you're inadequately dialyzed, he said you feel so bad that basically you go home from the treatment and you crawl into your bed and you sleep for the rest of the day. So he said, basically, I had no life. And I realized that if I could dialyze myself effectively, then I could actually begin to live life in a different way. And so he kept telling me how his clinical knowledge built the courage in him to ask the question about dialyzing himself. And then I asked the ultimate question, being a nurse and a CEO in my background. I said, but Christian, what about safety? And he said, well, of course it's safer in my hands. And I said, that wasn't what I was expecting him to say, you know. I was expecting him to say, well, I'm scared to death, but, you know, I can always call a nurse, or there's always a physician nearby. And it wasn't what he said. He said, first of all, he said, this is my own bacteria. And he said, you're introducing bacteria every single day from all these different people. And he said, I'm safer. He said, I've never had an infection when I've done it myself. And then secondly, he said, you all do it a little bit differently. He said, every person that comes in has their own methods, their own process, and their own supplies. And he said, all that introduces variation. I learned that as a mechanic, that you don't introduce variation to a standard process. So then I went and interviewed the head nurse. Her name was Annette. And I said, Annette, where did you find the courage to let this happen on your unit? And she said, well, first of all, she didn't know about it in the beginning. The nurse and Christian were just working together, and then the 73-year-old, and then it was rolling out. But she said that, interestingly, she said that they were using quality improvement, PDSA cycles, and they were working their way through it. And as they did, she found that the processes were much more reliable, and the complications were fewer. They had one of those big red, yellow, green charts on the wall that showed complications, and she said all the red turned to yellow and all the yellow turned to green, and all the doctors were walking around saying, we are really good, not having a clue that they had nothing to do with the improvements in complication rates. And then Annette started to see that her budget was going down. She wasn't spending as much money because patients weren't complicated. Patients started taking care of themselves. So she said her job became different. And I said, what is your job now? And she said, well, one day I looked out over the unit and I said, wow, I have 19 patients in here today. They're all looking a lot different, but none of them are working. And so she said, as her job as the head nurse of the unit, and I'm asking you to think about what you do, she said the first thing she does when a patient gets admitted to the unit is she sits down next to them and they write their patient's CV. And she said the reason is because what they said to her is what's really important is that I can work. That's the clinical outcome of dialysis, is that they can work. So she writes their CV with them, and once a month she has the County Unemployment Bureau come in, and anybody that wants to work, they start talking about matching up jobs. Now, where in healthcare in the United States do we ever talk about work as the clinical outcome? We don't often use that metric, and yet that's what these patients said was important. So at the end of the whole couple of days with these folks, I said to Christian, so Christian, did you go back to Saab Avionics to go back to work? And he said, no. And I was thinking, oh, this is a failure. And he said, no, I'm an RN. He said, I was at the hospital all the time anyway, so I went to nursing school. And he said, he's now the head nurse on the ENT unit at this academic medical center. And he said, it gives me much more meaning than working at Saab. But this is what happens, I think, when we start to think about care in a different way. So I interviewed Annette. She was this is the unit. So I want you to go back. Since I was there, I've gone back to, I've visited dialysis units from New Zealand to Vancouver, and I've not found one that looks like this. When Christian said, Annette was redesigning the unit, and she said, I'm making it look home-like. And she said, I'm investing a lot of money in lighting and artwork on the walls and warm colors and all that, and lounge chairs. And Christian said, do you care what we think? And so she said, of course I do. So he said, don't invest in that, making it look home-like. He said, excuse me, but he said, it's a hospital, goddammit. We don't want it to look like home. He said, we want it just to be convenient and clean, and we want you to take all that money you are investing in lighting, and we want you to invest it in exercise equipment. So these patients are on dialysis, and they're exercising. And I challenge you to go back to your units and look and see, is this what your patients look like? Most of the ones I look like are curled under sheets, and they're, getting fed, and they're moaning, and they're waiting to go home to post-dialysis bed. But they don't look like this. This is what happens when patients decide that they're going to take care of themselves. When I interviewed Annette, Britt Marie, the pioneer who said yes, I said to her, what gave you the courage to say yes when the patient said, I want to do it myself? And she said, I looked into his face and I said, I know he can do it, I trust him. And then she said, I trust myself, because she trains student nurses. So she said every July 1st, she gets this whole bevy of student nurses that don't even know what a kidney is, and she trains them to do dialysis. So she said, he knows a whole lot more about himself than the student nurses do in the beginning. So I just went back to that very first day and I say, okay, this is what we do. And I taught him just like I taught them. So now, this whole unit, this whole building is all patients that let themselves in the morning with a card key. I interviewed Ingrid. Ingrid was a nurse who's 64 years old. She's been a nurse for 40 plus years. And I said to her, where did you find the courage to move from being a nurse, a technical nurse, to being a coach? And she said, I found the courage in looking at the patient. She said, and she stood up and she said, this is what they used to look like. And she said, now they run in and they say, Ingrid, I'm going to get myself onto the equipment. And she said last Saturday, before I was there in May, she said she came in at 6:30 in the morning. She was sitting in her office doing paperwork. And she said she decided to go get coffee. She was walking down the hall, and she heard this guy saying, aren't you going to say hi to me? And he had let himself into the building. He was the only person in the building, and he had already been on dialysis for an hour. So I got the whole group together, Christian, Ingrid, Britt Marie, and Annette, and I said to them, so what else could patients do for themselves? And they talked among themselves in Swedish. They call it that. They say they have a Swedish moment when they go into talking in their own language. So they took a Swedish moment, and they came back and they said, oh, nothing. We don't think they could do anything. And I said, well, here, this is a very technical thing, and you've got all these patients doing their own dialysis. Could they do their own chemotherapy? Oh, no, that's too challenging. I said, do you think that women could have their own babies? If we had birthing suites, and we had the family, the mother and the father, and the doctors and nurses were outside if they were needed, but they could have their own babies. No, they could never do that. So even innovators need inspiration, and the inspiration is going to come from the patients. Now, what's great is that this idea, since I went there last May, I've told this story a few times. And when I was in Paris last week, a whole group of renal physicians and nurses from 2 different parts of England showed me pictures of how they have gone up to Jönköping now. They've brought it back, and they've already started building their own dialysis unit. So there are 3 starting in England. They're starting to spread around the world. And Chris and I were talking before the session. What's interesting was these patients are now saying that they take care of themselves, and they're so much healthier and happier. They say they even clean up after themselves. And I said, why do you do that? And they said, well, because we're very particular about the way that we like our supplies kept. And so it's easier for us to do it. But they're very happy to do so. But they said now, when they get admitted to the hospital for something else, they said they treat us like babies. All of a sudden, we can't give ourselves our own medications. We can't take our own vital signs. They said, we know how to do these things. And they said, we bring skill and assets to the encounters that they're credited completely in the dialysis unit. And when they go into the rest of the hospital, they revert, they regress. So I tell you this story to say complications are down, the patients are healthier, the cost is dramatically lower, and the satisfaction is through the roof. We need these kind of models, and we can't build them unless we get the patients in the room. Here's a Christian today, and so he's now looking at a life fully engaged as an RN. He is engaged in a wonderful relationship. He's looking forward to marriage and kids, and he's got his whole future ahead of him. It looked very, very different when he was under the care of the healthcare system exclusively. So I'm going to ask you to go back and think about what assets your patients have that we don't even know about. What do we take away from them when they come into the hospital? And how can we build on those assets? Really think about how can you redesign care with patients. It's going to blow your mind. So you need to find some innovators within your system and then give them a sense that this is okay, to really begin to think in a different way. And then I would say seek out the best innovations. Like if you're a CEO here in the room, and I see some of you are, it might be worth the cost of a plane ticket if you have a pioneer in renal to send them to Yunchipping. But find the best places in South Carolina, find the best places in the country, or find the best places in the world. We do have some volunteers, I see. There are great models out there, and the exploration is really going to open people's eyes. You can hear me talk about it, or you can read a peer-reviewed journal on clinical outcomes, but until you can, like I did, sit for a whole day with Christian and interview him about all of how this happened, it's really difficult to get the change concepts down. And then I'm going to challenge you again to think about the community. We talked about the patient, changes that need to happen at the patient level, changes that need to happen at the organizational level, and I leave you with some changes that we need to happen at the community level. And again, here with organizing Columbia, you've got the best step forward, I think, of most any place in the country. But think about what health really means. I'll start you with the Robert Wood Johnson definition of health. Health starts where we live, learn, and play. And then there's the determinants of health. WHO defines health this way: the conditions in which people are born, grow, live, work, and age. And then they put including the healthcare system. So as a challenge, I put up a slide that I use frequently, which is the determinants of health. We think that the healthcare system is what produces health, but this is really a map of the determinants of health. Can you find us? We're here. That's the influence that healthcare as a system has on health. So we can't do this alone. I go back to my beginning comments yesterday morning about breaking down silos. That's the influence that we have on health. So we need to start bringing in all of the assets we've got and beginning to think in a different way. I'll share with you one of my favorite things is Tom Frieden, the director of the Center for Disease Control, what he calls the health impact pyramid. And what he's doing here is he's describing how you get the greatest impact on health. And you can see up at the top, there are things like education and clinical interventions. The reason it's at the top of the point is because we do it a lot, but it has the least impact on health. Really, what we need to do is to move down. I'm asking everybody to think, how do we move down the pyramid and to think about context? How do we make it easier for people to do the right thing in health? Because if we keep adding more and more clinical interventions, we're never going to get the kind of impact on health that we need to have. So go into your cafeteria. Whenever I come visit hospitals, and I may pop in and visit you, first thing I'll say in the early morning is, can we go get coffee? And I just say that so we can go to the cafeteria just to see what it looks like. As I mentioned yesterday, healthcare is one of the most stressful jobs in the world. And a lot of us find comfort in food. If you're having a very stressful day and you walk into the cafeteria, does it look like this or does it not? And so go walk into your cafeteria and see. That's changing the context. This is these are pictures of a cafeteria that I took in Wisconsin. And the first thing you see is that the least expensive thing you can buy is healthy. The matter of fact, they inversely price things by the cheapest things are healthy, and the more calories and the more fat and the more salt, they make that the most expensive things in the cafeteria because they're changing the context. And then they changed all of the vending machines, not only in the hospital but in the community, so that when you walk in, there's only one row of candy, and it's the bottom row. And then the first things you see are healthy, and they have those little green things around everything that's healthy. So they price things differently. They make things more convenient. They label them as healthy. Everything's got calories on it. And so I was sitting in the meeting with all the hospital executives and all, And all of a sudden I said, excuse me, I need to step out for a moment. And they all thought I was going to the ladies' room, but I saw the guy filling the vending machine out in the hallway. So I went out and I said, he's the person with the data. He'll know. So I went out and I said to him, so tell me, since they started doing this, are you seeing changes in what people are buying? And he said, in the hospital, absolutely. He said, the context has changed. And he said, people are buying tons more healthy food. He said, it's totally changed what he restocks the vending machines in. Gas stations, not so much. He said, little shifts, but he can actually measure, this guy at the vending machine, the changes in volume for every single thing. He said pricing changed purchase patterns, labeling changed purchase patterns, but when you focus on the context, you're making these kind of changes. We're doing a lot of work now in Memphis, and again, we started by having all the healthcare leaders around the table working with us on things like diabetes and getting African American men to be tested for hypertension. There's a cultural bias in Memphis that keeps them away from getting that testing, and then looking at the health of families. And you can see all these doctors and healthcare executives talking among themselves and saying, yeah, we'll do this. We'll have more visits. We'll have more visits, or we'll give more free medication, or but it was always about this question I raised yesterday, will more healthcare produce more health? And we've realized that it wasn't working. So now, around the table is not only the healthcare system, but it's everybody else. It's the public health people. It's the school nurses. It's the church leaders. In Memphis, 95% of people in that community belong to a church. So we said we need to bring all of the church leaders into the room. And what was really interesting was sitting there and listening to the conversation between the church leaders and the healthcare leaders. Because at one point, one of the ministers in Memphis, he's also a doctor, but he was talking as a minister. He said, you know, to the healthcare leaders, you see the patients with diabetes twice a year for 15 minutes, and you think you're going to change life. You're going to change health. Twice a year for 15 minutes. He said, I see them twice a week for 2 hours. So he said, I'll take diabetes. You guys worry about something else. And that's exactly what he did. He changed the context. So what he did was he started serving healthy meals on Wednesdays when people came to church. And he said to people in the sermons, this is what you eat. This is what it looks like. This is the variety. This is how you put your plate together. This is what you eat. And then he changed all his sermons to talk about the sanctity of the human body and your obligation not only to God but to your family to take care of your health. That's changing diabetes in Memphis. Another 15-minute visit will not. So it's all about, can we move down the pyramid and think about, in our communities, how do we begin to engage everybody in breaking down these silos and working on health. So I leave you with these challenges to begin to think at the patient level, moving from what's the matter to what matters to you. At the organizational level, we're all in financially tough times right now, and the answer is not going to be cutting your budget. The answer is going to be, how do we use every asset, from the staff, skills and experience and desires, to the patient's will to help take care of themselves. When I talk to hospital executives in this country about what would happen if Britt Marie taught Christian in your hospital, what would you do? The honest answer many of them give me is, I would fire her. I would fire her, because we've got rules against that. And so we can stay in the silo and say, we're going to cut our expenses, we're going to dampen enthusiasm and innovation, and we're going to prevent Christian from taking control of his own health. Or we can look across the silos and begin to say, there's a different way for us to think about this here. And then move down the health impact pyramid. Walk around your hospital with new eyes and see, is the context about health? Is the cafeteria about health? Or is it like Michelle Obama said recently when she was giving a speech, and she said, you talk about health here in this conference room, and you talk about health, but when we walk down the hall to the cafeteria, you serve death. And she's really laying a very stern challenge on our table to begin to think about matching up what we say and what we do. So again, focus on asset-based care design, A, B, C, D. And someone came up to me yesterday and said, we need to add an E, someone here at the meeting, and that E is education. We need to involve all of the students in this so that we're bringing people along together. So I promised from today on forward, it'll be A, B, C, D, asset-based care design and education. And then really think about the lessons that so many have taught us today. Just from me, see the silos and break them down. You know, begin to think about Ethel on the painting. And is there a way that you can find out that someone needs a dog? Ask a colleague what matters to you. See context everywhere. Segment a key population and think about Christian. Is there a way for us to redesign care for one segment, for one population that's going to produce dramatically improved outcomes at a much lower cost? Sign your Healthy Columbia pledge and get going on that personally and go for the gold. From a tool said, you've got innovators in your operating room. It's not complete yet. But he said, find those innovators and help them. And then he said, find the barriers. And I'm adding, find Chris. Find Chris and ask Chris in your hospitals to tell a story about what a difference the checklist made, because Chris here powerfully moved everybody in the room yesterday when he said he personally, a well-respected surgeon, learned a lesson through the checklist process. And then from Eric, we learned that you need to see the context and the setting. You need to really, I would say, travel with one patient across the journey and see the handoff, see where the right setting is for the right kind of care. That whole notion of redesigning care across the continuum, I know in talking to many of you at breaks, you found that very challenging. But the best way to overcome the challenges is to see the journey for yourself. Design an agenda to prepare patients and their family for self-care. Or call Christian. Christian is the most amazing spokesperson. I met him in May, and he did a plenary session with the CEOs at the forum. And so here's a mechanic turned RN who stood up in front of several hundred CEOs and said, yes, we have a lot more to contribute that hasn't been heard yet. And then work on the receiving side. As Eric was saying yesterday at IHI's work on the STAR project, we found that the receiving side was totally separated, that most primary care physicians didn't know that their patients had, in some cases, even been in the hospital. I talked about my brother-in-law yesterday, and I kept thinking, if his primary care doctor could see him, then he could manage his pain. He could manage his diet. There's so much more his primary care doctor could have done to take care of him. But there's a rule in this academic medical center because of hospitalists that said, once you're admitted, your primary care doctor can't come in. And once you go home, then your primary care doctor has to fill in the blanks, but that primary care doctor is still waiting for the discharge summary. Those are the fragments in our system that we need to close. And then from Dave this morning, we heard some very powerful words about 5 design skills and about 16 design laws, a new way to think about really managing the cultures in our organizations. So I send you back to visit each other. If you have not been out to visit another hospital or another setting in the last year, I ask you to make a pledge to me today that you will, because walking into another renal unit or walking into another emergency department or walking into another office gives you new eyes, new ideas. You'll be inspired. You'll see some things that you never want to copy, and you'll see a whole lot that you do want to copy. Engage everybody as you have, from the boards of trustees right down to the front line. We saw that very powerfully yesterday with so many people from different parts of the organizations learning from each other. I would say map out the trajectory. We use a tool called the half-life. If you decide you want to decrease something by 50%, put a date on it and draw a line between today and that date. And it will tell you that you really need to start working right now. Tempo is critical, and you won't get the sense of how urgent it is until you draw that half-life line. Escape the silos and have fun. It's been an amazing couple of days, like it has been for me the past couple of years. I've learned a ton. I go back inspired with your stories, and I look forward to working with you all, with Thornton and Rick as the leaders here, with the leaders of, with Jay from the Health Sciences Research, and from all the folks at Blue Cross in this next year to make the same kind of differences that we've mapped out today. So thank you all so much for being here. Some of you in person, some of you virtually, and good luck on your journeys.